And the consequence of that is just complete access to puberty blockade and puberty blockers and cross-sex hormones in the community, many times being prescribed by practitioners who really have no business prescribing hormones at all, let alone in a cross-sex fashion.
I've heard from one person at least that Planned Parenthood is now
Yeah.
giving access to hormones.
Yep. Some of the community clinics and some of these places are staffed by, uh, um, different names, physician extenders, or they're nurse practitioners essentially, without the expertise training in these fields. And then in terms of, so then you asked about, blowback otherwise. Well, I think, I think there's risk, of course, to standing up and saying that you don't agree with, by standing up and saying the emperor has no clothes. There's no data here. There's no proof this works. There's lots of proof that it's risky and dangerous. There are other treatment modalities. Yeah, there's risk to doing that. It's a very emotional topic for most people. It adds another element of stress, and I think most physicians are opting out of that.
But this has the potential to basically neuter a generation.
Well, I think eventually what's going to happen is the sheer number of individuals who have been, so when you apply an unscientific process or thought process to reality, okay, you get bad outcomes.
Yeah.
And that's what's happening. So applying the already controversial Dutch protocol of puberty blockade and cross-sex hormones to adolescent onset gender dysphoria, for example, okay, which we really don't understand at all in terms of duration. It looks like many of these, predominantly girls, but boys as well, have autism spectrum conditions, very concrete thinking. Oh, I don't like dresses, so therefore I must be a boy.
Yeah.
Right. So treating a young girl like that with testosterone, it makes no scientific sense. So when you apply unscientific principles to the real world, bad things happen. And then eventually those people who have had bad things happen to them start to stand up and say, look, something bad happened to me. Look at the consequences of applying this unscientific treatment protocol to real life. And eventually the weight of the number of people hurt by this will, I believe, force some global awareness and change and reckoning.
Why? I guess you might not have enough data to have a conclusion about this, but I have to ask it anyways. Why are these authoritative institutions? How did they get captured by this way of thinking? Why are they going in this direction all of a sudden and so strongly?
Yeah, that's a good question. I mean, I could theorize. I don't know. So this has been written about, actually, other psychiatric crazes, they're called. So essentially, the populace, led by a few physicians, comes to conclude that a somatic treatment for psychic distress is a good idea. And it's almost like it has a life of its own once it gets started.
Yeah.
And then it basically starts to burn out once everybody realizes it was a horrible mistake.
Yeah.
And in the meantime, you're left with multitudes of people who've been harmed. And unfortunately, after at least what I've read, that there doesn't appear to be much reckoning. It's almost like, well, we were just doing the best that we could.
Yeah.
We were just trying to help. Yeah, but you abandoned scientific principles along the way.
Yeah. Yeah. And on top of that, from some of the research that you shared with me, this is going to disproportionately affect an already marginalized group, namely the homosexuals or bisexuals, are the ones who are going to be uh, who end up naturally getting through their gender dysphoria. So
Yeah,
if all these let's say lesbian women and gay men are
yeah,
tracked onto this body modification, um,
correct.
it seems like a very weird form of homophobia, or like, but a very aggressive regime of stamping out homophobia by
Yeah,
modifying the body.
yeah. So Deborah So has written about that. Yeah, that's an underlying theme here is that kids with gender non-conforming kids. So a girl, for example, who has preferences for masculine behavior or uh, dress, etc., young in life, probability-wise, may be same-sex attracted lesbian later in life.
Mm-hmm.
So by interrupting pubertal development, you're you're halting that individual's development the way that it's supposed to go. And yes, that's been written about as well. I mean, in Iran, for example, sex reassignment surgery is very popular because homosexuality is illegal.
Hmm.
So you're not allowed to be same-sex attracted. It's actually punishable, right? And,
Mm-hmm.
sometimes by death. And so, well, we'll just fix that, quote unquote, with cross-sex hormones and either masculinizing or feminizing surgery. And the reason I use that term is because you can't reassign sex, right? It's impossible. No one is born in the wrong body. You know, so it is essentially a cosmetic
Mm-hmm.
intervention
Mm-hmm.
for some root psychic distress, some psychological distress.
Yeah. Yeah. Or sociological, I guess, punishment or reassignment in the case of Iran.
Yeah, yeah,
Just to go back a little bit, when you were talking about puberty blockers, it
hmm
just made me think that it seems like people confuse it like you're just holding a kid back in school and you're giving them extra time to development and to develop. But it's
yeah,
actually the opposite of doing that. You're freezing them in time, on
yes,
not just physically, but well, I guess the body is one whole thing. So you're not
yes,
just allowing the brain to proceed while the body
correct.
waits. Like the whole thing is stopped.
That's exactly right, and that's one of the major concerns that's been raised in the literature. Um, by those, there was a study done. They surveyed clinicians working in gender clinics using puberty blockers, and these were the concerns that they raised. So even the folks in them doing this are
Mm-hmm.
concerned that this is occurring. No, that's absolutely right. And again, back to Carl Hennigan, right? These drugs are being used. Puberty blockers are being used. The editor in chief of the British Medical Journal, right? Someone who should be taken seriously. These drugs are being used in the setting of profound scientific ignorance. And so, if you look at his editorial and then go look at the literature, if someone is actually wants to know the truth about this, uh, there's no other conclusion to be drawn.
Wow. Wow. So, what do you think needs to happen then? The professionals need to be better educated. Can should the I guess the populace needs to be better educated too about the dangers of this, and
Yeah.
maybe some pushback against the. I don't mean this totally negatively, but the trans lobby or whoever it is that's really pushing this on a societal level.
Yeah, I mean, I think the truth has to be told about what's occurring on all of those levels, at every level. And thankfully, the Royal College of General Practitioners in the UK just, I think it was last week, last week or 2 weeks ago, basically told the truth and said, okay, gender and sex are not the same thing. Um, and there's no evidence that affirmation therapy works. And so we're essentially running an experiment outside of experimental protocols. So we're running a giant experiment, and that's not how medicine is supposed to work. You're supposed to do the experiments first, show that the treatment works, especially when you're talking about infertility and sexual dysfunction long term, and a fourfold, a 4 times increased risk of heart disease and a 2 to 3 times increased rate of development of blood clots and strokes. And the data we have now shows a 20-fold increased risk of suicide long term. So if we're going to go down that treatment protocol, there better be very good evidence that it works. And that evidence does not exist. And it runs contrary, like I said, this entire approach runs contrary to how we practice medicine in every other area. If the brain and the body are in conflict, we work on the brain, we don't work on the body.
Mm-hmm. And so why is that? Because the brain can change, or because messing with the body is more fatal than messing with the brain? Like, what's the reason for that?
We have to agree that there is some fundamental reality that we exist and operate in, and that we can identify that reality with our senses and measurements and agree upon that reality, that XX and XY cells are different and they respond differently to hormones. And so once we agree upon that reality, if someone is at odds with that reality, we need to help them back to reality, not keep them away from reality.
Well, how do you do that on a social level? How do you re-steer a society back to reality? Just let it crash against the rocks and expend a bunch of lives until they stand up?
That seems to be what's happening with these crises over and over again. So if you look at the opiate crisis, right? I mean, here's a non-addictive opiate. Oh, really? No, it's not. And how many people had to suffer before that non-reality, right? So you take a bad idea, put it into reality, and you get a bad outcome.
Yeah.
And so that's what's happening, and I think unfortunately it takes significant suffering for society to wake up to that reality.
That's not an optimistic outlook, but it seems realistic, though.
Yeah, no, I have some optimism more recently because of the Royal College of General Practitioners.
But the World Health Organization is going the other route, from what I've heard.
Yes. So, but at least now there's some pushback where on an individual basis, individuals who are caught up in this can have a chance now of making a decision, at least based on some more factual based information.
Truly, or at least more informed consent.
Yeah.
And what about your role? You speak about this on Twitter, and your Twitter presence is really appreciated, and at least for me and then other people, because you're bringing up facts, and you're really standing with a lot of people who are bringing up facts. Do you have any plans to, or are there other people in your profession that you think will converge on doing what you're doing, or is there any movement towards like a collective of endocrinologists?
So I think privately, yes.
Braverly? Oh, okay. So it's
privately. Publicly, I don't see that yet, but I think eventually that will happen.
It'll spill over.
Like I said, eventually the consequences of the application of this bad idea will be so evident that any except the extreme ideologues will be forced to accept what's happened.
And do you get referrals from people with gender dysphoria?
A few. So you brought this up initially. Most kids now who have gender dysphoria, they want puberty blockers and cross-sex hormones. And so because I don't do that, they're not going to come my way.
Okay.
So these kids are presenting to the primary care offices, and then the primary care docs are confused as to what to do. How do I handle this situation? Do I send them for counseling? Do I send them to somebody who's going to put them on puberty blockers? My experience up to this date, right, has been adults with autogonophilia. That was the predominant presentation for adult endocrinologists. And then this new adolescent wave, most of them are being funneled to so-called gender clinics. So,
are these gender clinics, they're just sprouting up, I guess, to meet the demand? And are they, what is a gender clinic? What is it based on? It seems like that's a kind of a gender studies thing. It's like it's taking some science and then it's framing it in an ideological.
So I think in 2010 there were 8 designated gender clinics in this country, and now there are more than 50.
Okay.
And it's what you said, essentially meeting this demand for individuals who wish to be treated with cross-sex hormones. And so that's what they're offering. They're offering affirmation. There's no oversight, so I don't know exactly the clinical models that are being used in terms of what we're hearing is that more so it's informed consent. So you sit down with a brochure. Here's what testosterone is going to do to you in the ways that you think will help you. And there's other things that might happen. It's kind of mentioned in there.
Mm-hmm.
But it's really not a true informed consent process. And I think there's a lot more to be said coming about that as well. How do you consent a 14-year-old to lifelong infertility? How do you consent a stressed 17-year-old to permanent voice changes, increased risk of heart disease, and all the other physical changes that can occur that can be irreversible from testosterone? So it's a real problem. I mean, again, under normal circumstances, so we've got like 2 different ways that medicine is being practiced now. So gynecologists will not perform elective hysterectomies on women under the age of 25 unless there's some emergent reason. And the reason is because they understand that the human brain is not fully mature until at least early 20s, maybe mid-20s. And if you've got somebody with an autism spectrum condition or something else that may have caused delay of development, they may not be mature till late 20s to make a decision about permanent infertility. So that's how regular medicine works. And then we have unscientific medicine now, where a 14-year-old can elect, apparently is competent enough to make a decision about lifelong infertility. The two can't exist in the same space.
So the one has to go and move into a little special clinic where they perform, half-off mastectomies on Valentine's Day and stuff like that.
Yeah, you saw those advertisements for double mastectomies, right? So it's really unbelievable. I guess that's the only way to describe it.
It's horrific, and it's thoroughly odd. Unless you trace it back to some sort of ideological precedent that was set up, I think in the universities with gender theory or some sort of something like that introduced this idea, and the idea took weight and took hold. Or maybe it's.
So I haven't dug much into the origins of this approach, which has essentially so counseling as a treatment for gender dysphoria was abandoned back, you could say essentially abandoned, I think it was in the 50s and 60s by 3 physicians who are considered the founders of transgender treatment. A guy named, I think, John Money, I don't know how to say his last name, Harry Benjamin, and Kinsey. And if you read about these guys, it's not a pleasant read in terms of the types of experiments they were doing on people, but really this concept of we're going to treat the body, not the mind, got started then.
Okay.
And because it was not affecting many people, like I said, this was only 1 out of maybe 20 to 40,000 people.
Mm-hmm.
Nobody was really paying much attention. And that's why this was able to go on for many years. And like I said, up until 2010, there were only 8 gender clinics in the entire country. Because it was only after, so if you allow people to go through puberty who have gender dysphoria, the majority resolve. And so you would only be left with a small percentage who then would have persistent gender dysphoria, who would then go on to cross-sex hormones and surgery. And you had Ray Blanchard on. He described how cautious they were, right? Live as the opposite sex, then do the cross-sex hormones, then do the irreversible surgery. But all of this is occurring in young adulthood. Now, you can even make a case based on the recent studies of heart disease, blood clot, and long-term suicidality that even that approach should be seriously reconsidered. But that approach, so that was 1 out of 40,000 people in the general population. So this unscientificness has been present for a long time. It just didn't affect many people. But with the onset of the puberty blockade and this now adolescent onset gender dysphoria, we're in a completely different world.
And again, how do you steer the ship back? But I guess you just need to let it happen, or speak up as you're doing right now and as other people are doing right now.
Yeah, you just basically lay out the facts. You say, look, here's what's happening. Here's what the data shows. If you're going to apply the scientific process to this aspect of medicine, we need to apply it to this aspect as well. And then you make your case. And from personal experience, I've talked to, I don't know, 24 physicians at this point, kind of in a real sense, not just a passing conversation. Okay, sat down with them, explained the literature. Now, don't take my word for it. Go research it yourself. I've provided you the references. Go do your job. Go figure out how best to treat these people. And when they do that, it's obvious to them that, back to Carl Hennigan, his statement is absolutely correct. It's unproven and unsafe. And there's really no other conclusion to be drawn from the literature if you take an objective look at it. And so that's, I think, ultimately where this has to go. And if we can break through in the main medical meetings, I mean, it would just take one simple presentation from someone critical of affirmation therapy to dramatically shift practice patterns.
So you need a reality blocker regimen.
Yeah, we need more reality, which is always the case.
How we need to start wrapping up because I have to take off. But I would like to know if you want to tell us how did you get into this field of medicine? How did you end up doing this work?
So I'm a general endocrinologist in the community. So the way that this works is you go through medical school and then you pick a specialty. Okay, do I want to be a surgeon or do I want to be a cutter or a talker, essentially? Is really kind of the initial decision that you have to make. And I saw the lifestyle of the surgeons was just brutal. I mean, they were doing incredible work and saving lives, but immediately, in the immediate sense, the talkers, the medicine doctors kind of save lives over the long period of time. But so that was the first decision-making point is medicine or surgery. So I chose medicine, and then happened to run into a great endocrinologist where I was training, and went through 2 years of endocrinology. So basically what happens is we pass internal medicine boards, and then we do 2 years of additional training, and then we have to pass endocrine boards. And then at that point, we are considered and expected to be, and appropriately so, experts in all things hormonal, regardless of the frequency of presentation in the population. So diabetes is much more prevalent than acromegaly, for example. So it might be acromegaly twice a year, right? Excesses of growth hormone, or But we're expected, and rightly so, to be experts in all areas of hormonal excesses or deficiency, and gender dysphoria included. Although I would argue that is not a condition of hormonal excess or deficiency. This is a
Psychosocial.
yeah. This is
Phenomenon.
not an endocrine problem, but because I would
Huh.
say psychiatry and psychology as a whole, there are obvious exceptions, and you've interviewed exceptions, have
Deferred it.
abandoned. Yeah, they've essentially kind of jumped ship on this condition,
Hmm.
and so now the endocrinologists have to step up and say, well, wait a second, it's quite easy for a psychologist or a psychiatrist to call the endocrinologist and say, oh, you got to give this girl testosterone. Well, they're not going to be the ones called to the bedside 2 or 3 years later, or 4 years later, or 5 years later, when that individual has had an MI and they're in the intensive care unit, with their family around them.
Hmm. Hmm.
So the prescribers of these drugs have a responsibility to um, uh, understand the consequences of prescribing and to make sure that there's a clear indication, and there is not one in this situation.
Okay. Do you think that given enough research, there might be, are there some exceptions to this then? Because I've met some pretty amazing people who end up transitioning their sex,
Hmm.
but that comes with a risk.
Yeah,
And the ones that I've spoken to really lay that out and stress
yeah,
the
yeah,
cost
it's
benefit.
yeah. That's a conversation that has to be had,
Yeah.
and it has to be had based on, well, I mean, it can be had on multiple levels, but from my standpoint, it's a scientific discussion, and then
Hmm.
a philosophical one, perhaps, but we have to look at the science. And then if we're going to say that, okay, the science says it's not safe on whole, right? So we're looking at increased risks here, percentage wise, et cetera.
Hmm.
Okay, if we're going to abandon the approach that we use in every other process, well, we better have a lot of conversation about why and how that's going to occur. Uh, and that's how those things need to be figured out.
Hmm.
Scientifically, I mean, the data long term is just abysmal.
Hmm.
I mean, doctors immediately stopped prescribing hormone replacement therapy for postmenopausal women when a study came out showing um, it was about it was like a 15 to 20% increased risk of breast cancer and heart disease.
Which is significant.
Which, yes, so
One in
so
five, 1 in 6.
right, but we're talking now about a 300% increased risk of heart disease from testosterone. So
Because
so
they're
if we're,
taking it so long?
yeah,
Okay.
so we're looking at a 15% risk, and that immediately caused almost an immediate cessation of prescriptions for postmenopausal women. And there have been some modifications of that. It looks like it was that particular formulation, et cetera,
Hmm.
versus now a 300% increased risk of taking testosterone. So that's why I'm saying that we're in serious disconnect, and the only way this is going to be resolved is conversation, and that's being suppressed.
Hmm. Hmm. Dang, this is a really dire episode. Thank you for sharing
Yeah.
your expertise. How complex is endocrinology? Just as comparatively, I don't even know if this makes sense as a question. I'm just trying to figure out like how complex is this system that you're dealing with?
So, well, for those of us who are in it, it's not that complex. But for those who are not in it, it is full of complexity,
Hmm.
and it takes a while to understand the subtleties of hormonal feedback
Okay.
and how to manipulate those systems to help people achieve better health. So
And
yeah, it's a fairly complex subspecialty.
have you studied this in relationship to evolutionary biology, or how it kind of propped up itself, how it grew over time, like just uh, in
It's
biology?
Not
Okay.
specifically.
Are there studies on that, just showing how the mammal constructed itself over time into this complex, weird form of juices all
Yeah,
interacting with each other?
yeah. Well, I can give you one example. So metabolically, if you burn sugar on the stovetop, it turns into like a sticky material. Have you ever seen that? Right?
Yeah,
Or
yeah,
you know
caramel
what?
or
Yeah, you know what creosote is? Like if someone has a wood stove, they're they have to clean the pipe of the stove out periodically, or else the byproducts of any carbon-based fuel being burned results in this sticky material, and it builds up on
oh, okay.
stuff. And so glucose, sugar, is essentially a carbon-based fuel for us. Okay, we're
Okay.
flex fuel. We inhale oxygen, um, and then combine that with three different sources of fuel. So we've got fats, which burn pretty clean, proteins, which burn dirty, which is why we've got kidneys.
Hmm.
Okay, so the kidneys clean out the byproducts of protein metabolism, the urea, the nitrogen.
Okay.
And then glucose is its backbone is carbon. And so when it burns, when you combine glucose with oxygen internally, okay, which is a metabolic process, right? We're essentially a combustion engine to
Yeah.
generate heat, okay? That process results in the formation of that sticky stuff internally as well. And so if you have
Huh.
too much so glucose is a very potent energy source, and it would be, from an evolutionary standpoint, of great advantage to be able to consume carbohydrate, but as a consequence of its metabolism, not die. Okay, so if your blood sugar is too high and you're developing too much of that sticky stuff buildup, that
Yeah.
sticky stuff clog up small blood vessels, and that's what causes the damage of diabetes. So the eyes, the kidneys, and the nerves have the smallest blood vessels. They get clogged with the byproducts of glucose metabolism if the sugar is too high in the bloodstream. So the body developed a way so that we can consume carbohydrate, but immediately store it as an energy source that we can burn later. And so we developed the capacity to make insulin, which takes
Okay.
glucose out of the blood, stores it as fat. And when fat burns, it's pretty clean. I mean, think about a candle. When
Huh.
it burns down,
Yeah.
there's a little byproduct, but it's a pretty clean burn.
Hmm.
And so we essentially evolved the ability to consume a high energy source that is toxic. Carbohydrates are toxic, but then store that as, with the use of insulin, as a non-toxic fuel.
And
Now,
what produces the insulin
the
in the body?
pancreas.
Okay.
Yep.
And so diabetes is when you're treating diabetes, you're treating the pancreas. And why does diabetes generally occur? What is the
So you got two types of diabetes. So type 1 diabetes is pancreatic failure. So in terms of insulin production, so digestively you're okay, but the immune system attacks the pancreas, and the pancreas's ability to make insulin goes away. Insulin levels go down, and so we have to replace that with injectable insulin. Type 2 diabetes results from excess body weight. It results from essentially an excess of calories, so overconsumption of food versus burning of that energy, of that food, resulting in obesity. The pancreas tries really hard to maintain normal blood sugars because glucose is toxic, but eventually it burns out, and that's what leads to type 2 diabetes. So as an endocrinologist, essentially, got two tasks with type 2 diabetes. The first is to normalize blood sugar using diet, exercise, and medication, and sometimes insulin. The second task as well is to help the patient understand what led to the obesity, what chronic stressor
yeah.
caused the overeating that
Right.
led to the obesity that then led to the type 2 diabetes.
Yeah.
So basically, okay, let's use these medications to help you with your blood sugar, but let's also get to the root of the stress.
Huh.
Why are you overeating? The that's another endocrine system that is very interesting. So if someone is chronically stressed, their stress hormone levels, cortisol and adrenaline, go up. Cortisol and adrenaline deplete dopamine levels centrally in the brain. So you're not supposed to feel well when you're stressed.
Yeah.
Okay. Sugar increases dopamine
Oh, yeah.
temporarily, and it does
Huh.
so in a fashion where the more you get, the more you want.
Yeah.
Those dopamine receptors downregulate. It's just a classic addiction feedback cycle. So,
Hmm.
so that's the second thing that endocrinology should be helping patients with is understand, okay, you're chronically stressed. What is the reason for that? Because we need to fix that so that you don't continue overeating.
Yeah. So you're doing the accommodative technique, which is therapy and I guess medicalization. You're trying to
I guess
combine
you
those
could
two.
say that. So it's essentially treating the end result of the condition, but also trying to stop it from getting worse by most of the time, the reason people are chronically stressed is they are exceptionally poor at standing up for themselves.
Hmm. Hmm.
And many who have severe obesity as well, they have a history of trauma as young people. This has been studied and known as well. And so there's certain characteristic stress patterns. I mean, right? You've heard that term, "only the good die young."
Hmm.
Okay, so doctors know. We know that it's usually the really nice people who get sick.
Huh. They're
Okay,
susceptible.
they are too nice. They're in a chronic state of stress,
Huh.
and their cortisol levels. This is my theory. So taking this from practice to from this is my theory, at least, just observations of different types of personalities that tend to get sick.
Yeah.
I mean, when I went through my rotation, oncology rotation, the first thing that senior resident said to me is he said, you're going to notice that it's nice people who get cancer. It's the nicest people who get cancer. And
Huh.
he was right.
Because they're like bearing the weight of the world or something like
Essentially,
that.
they're in a constant emotional state of appeasement.
Hmm.
This is my theory on this, okay?
Okay.
And many of us now, we have counselors embedded in our clinics
Okay.
because we know there's a high rate of depression and anxiety, which are essentially result from chronic excesses of stress hormone and really not being able to deal with uh, being susceptible to the stresses of life. I'll put it that way.
Well, not setting boundaries in a sense, then.
Correct. No
Just.
boundaries, putting everybody else first,
Hmm.
really having a hard time saying no.
Yeah.
And as a consequence, their fight or flight system um, is cranking out lots of cortisol.
Hmm.
Again, this is theoretical.
Yeah. You're not
These
just
are my
telling everybody to buck up.
learn how to stand up for yourself
Yeah.
and set
Huh.
boundaries with people. Right? You don't have to be a jerk.
Yeah.
Just expect the same level of respect that you give everybody else, because
Hmm.
these folks they'll put themselves dead last. Everybody else is first.
Hmm.
And this starts at a very young age. So these are the sorts of patterns of stress that we see over and over again.
Yeah.
And then we can show people, like, look, you're going to feel better when you set some boundaries. You don't feel like you're going to be at the will of everybody else. And you're going to notice that you're less hungry for foods you don't need.
This
Carbohydrates.
sounds pretty amazing because I guess the tired criticism of Western medicine is that it just treats everybody as an object, but it seems like your discipline, at least, is moving towards a more holistic understanding of the human being and trying to really service them on all levels.
Um, I think I am. And there are others who are starting to think this way as well.
Oh,
So
okay, okay.
it's like, okay, yeah, stress plays a role in probably the onset of illness through disruptions of immune system function
Hmm.
and makes it worse once you have an illness. And so, stress management absolutely has to be part of any treatment protocol, in my opinion.
Hmm. It's just so fascinating to me, just as a poet, to think that somebody who has a hard time setting boundaries, their immune system has a hard time regulating their actual boundaries. It
So,
just.
so that's an interesting way to look at it. I mean, the link there, the biochemical link is through cortisol. So cortisol is a very potent. It's a steroid. It's essentially internal prednisone.
Mm-hmm.
Okay, and it's released when we're under stress.
It's kind of toxic in high
Yes,
doses
it,
then.
it, it basically the purpose of cortisol is one of the purposes is to raise your blood sugar to feed your muscles so you can fight or flight.
Okay. Okay.
So if someone is in a chronic state of fight or flight for whatever reason, night shift work, abusive relationship, past trauma they haven't dealt with, just generally being taken advantage of everywhere they go because they don't know how to stand up for themselves. There's some studies showing that that approach to life, your limbic system essentially stratifies you in a hierarchy, in a social hierarchy, so that if you are not standing up to people, your fight or flight system is waiting for this person to come and take your stuff.
Yeah. Okay.
Just like a monkey troop or a chicken coop essentially. So it's an animal-based hierarchical system
Yeah.
where if you're not holding your ground, your fight or flight system gets you ready to be taken advantage of at any point in time. Your resources, your food, your mates, the whole thing, right? Going back to an evolutionary biology standpoint. And so, and that creates a constant state of anxiety because the cortisol depletes dopamine levels. And in addition, cortisol inhibits normal immune system function.
Mm-hmm.
So someone who's chronically stressed is going to be getting sick more often.
Mm-hmm.
And we see that as well. I mean, you can induce that with overexercise. It's simple. So marathon runners, if they're running more than 90 minutes per session, and there's a certain threshold, they all know when they get closer to training, their susceptibility to viral infections goes up.
Okay.
Because with the overexercise, they put themselves into a chronic state of stress, excess cortisol, inhibition of immune system.
Mm-hmm.
So the cortisol knocks down immune system function, knocks down dopamine. So then we will turn to whatever source of dopamine we turn to, and it can be socially acceptable or socially unacceptable.
Yeah. Yeah.
To temporarily relieve that feeling of anxiety caused by that dopamine depletion and serotonin depletion. And then at the same time, our immune system's dysfunctional. And I'm of the thought that some people will be more susceptible to bacterial and viral infections. Others will be more susceptible to autoimmune disease. And others, our immune system is the main defense against malignancy. Mm-hmm. Right? So if a cell develops that doesn't look like it should, our immune system should immediately kill that. And it appears that all of us develop cancers continuously through our lifetime. Yeah. And then our immune system just kills them. Yeah. But if your immune system is chronically depleted from excesses of stress hormone, you're more likely to get cancer in theory. Again, that hasn't been directly proven, but it's really interesting that the main, and I'll shut up here in a minute, the main treatments now being developed for malignancies are immune system based. You essentially hypercharge the immune system so that it will circulate these white blood cells, these killer T cells will circulate, identify abnormal cancer cells and kill them anywhere in the body.
So you empower the internal editor rather than like shooting laser beams into the person to kill it.
Exactly.
Huh. That sounds smart, even if it might be tricky to do correctly.
I mean, so the immune system is like a lion, a tiger in a cage. Mm-hmm. So if it overactivates, it can cause a significant problem. And
like you were saying, it can attack the pancreas. It can single out organs to go after.
Correct.
Fascinating.
Yes.
You could talk forever. This is great, and I'm surprised that you don't go around and give talks at these conferences and stuff.
So I do locally. What I desire most is a quiet life in the country. Yeah. Believe it or not. And so I haven't made it a point to put myself out there. So I will do local talks, and everything I just shared with you, I will share with patients if they're under stress, and say, look, we've got to give you some skills to deal with that chronic stress. In certain ways. So yeah.
Well, I probably can't get you on Bill Maher, but I could boost your profile just a little bit.
All right. Sounds good.
Thanks so much, William, for your time. This has been an excellent talk. I think this is really important, a part of the series, and I hope that this gets circulated so that scientists and people who are needing this information can hear it and maybe spark more conversation along these lines.
Yeah, I hope so. Yeah, appreciate that.
Yeah. Well, happy insulin. I don't know, how do endocrinologists say goodbye? Do you guys have a special
No,
hormone handshake or anything like
no. If there is, no one has showed me yet.
that? Okay. Yeah, right, man. Well, have a good day.
Okay, thanks, Benjamin.